Welcome everybody to our Building Climate Resilient and Environmentally Sustainable Health Facilities in the Americas. This is a webinar series with 5 sessions. We are in session 4, and today we are going to talk about empowering the health workforce and other relevant stakeholders. My name is Danielle Magalhães. I'm the Senior Project Director at the Global Consortium on Climate and Health Education at Columbia University, and I will be your moderator today. So we have in this session interpretation in French and Portuguese. You just need to using the button within the globe and select your preferred language. This webinar series has a couple of webinar learning objectives, which are understanding the principles and benefits of climate resilient and sustainable health systems, including how healthcare facilities can adapt to climate change, reduce greenhouse gases emissions, and align with global and national climate priorities. We also want to identify practical solutions and innovations in energy, water, waste management, facility design, and operations that strengthen healthcare delivery while reducing environmental impact and operational costs, and strengthen the capacity of health professionals and stakeholders to plan, implement, and advocate for sustainable and climate-resilient healthcare facilities through collaboration, case-based learning, and access to existing guidance, framework, and network. As I said before, we will have 5 webinars. We are in the webinar number 4 about empowering the health workforce and other relevant stakeholders. We will have our 5th webinar in March. We still deciding the date, but we will make sure that you have this in advance. So this webinar has the objectives to describe the roles of healthcare workers, researchers, and policymakers in advancing climate resilient healthcare facilities, access existing initiatives, resources, and networks that support health workforce capacity building for climate resilience, and identify actions to improve working conditions and empower healthcare staff to respond effectively to climate-related challenges. Today we will have 5 presenters, but we will have 4 presentations. I will open the floor for our first speakers, Dr. Bob Mesh. Professor Mesh is an executive head of the Department of Family and Emergency Medicine at Stellenbosch University, South Africa. He has led several research studies on climate change and primary health care in the Africa context. He is a faculty of medicine and health science and a member of the Global Green and Health Hospitals Network, along with the Department of Health and Wellness in the Western Cape, South Africa. He is currently the president of the World Organization of Family Doctors, the WONCA, Africa region, and he is the editor-in-chief of the journal, African Journal of Primary Healthcare and Family Medicine. It's an honor to have you here, Professor Mesh. And if any of the participants has any questions, please include your questions in the Q&A so we can have a discussion at the end of the session.
Okay. Yes, thank you very much for the introduction. It's great to be here and see so many people attending the webinar. So I am, as was said, I'm a family physician based in South Africa and working primarily from a sort of primary healthcare, primary care perspective. So that's where I'm coming from. So I've been asked to speak about this topic of empowering the health workforce in sub-Saharan Africa. I'm going to share a little bit about continuing professional development for the primary care workforce, and then a little bit about postgraduate and undergraduate education initiatives, particularly sharing our experience from Stellenbosch. So now I just need to get to my buttons. Um, yeah, so just to remind you who we're talking about when we think of the workforce, and of course, I'm thinking particularly of those in the district, the primary care and the primary hospital in the African context. So we're thinking sometimes of doctors and family physicians, but more often actually of clinical officers. Some people call these physician assistants, of course, midwives and nurse practitioners, community health workers, very important member of the team, and then pharmacists, pharmacy assistants, and then a whole range of other people, particularly therapists like physio, occupational therapists. So these are the people that we're thinking of. And I wanted to start by talking about continuing professional development because, we have an existing workforce, and we suspect that most of the existing workforce have not really thought about the sort of planetary health and climate change issues when it comes to their clinical work. So, in fact, we did a survey through the Prima Famed network. So most of the respondents were family doctors, family physicians from 24 African countries, and it included, I think, 38 different institutions. And it was interesting, 61% of our respondents had never, ever had any continuing professional development on the topic of any topic related to planetary health. And the main reasons they said was, well, first of all, it's not really perceived as having much clinical relevance to them. The institutions that they work for don't really support CPD on these topics, have not really prioritized it. And then lastly, that there are very few, from their perspective, educational resources that enable CPD on planetary health topics. So when we drilled down, though, with them, we were able to get these results in terms of the top planetary health topics that they thought should be included in CPD for primary care providers. So the top topic, of course, was how actually does climate change and the sort of the ecological crisis impact health, and what is the pathway by which that happens? And of course, there's a whole complexity to this that needs to be unpacked in terms of the sort of intermediary factors and the mediating factors, and then the health and social effects of the ecological crisis. The second topic was community-orientated primary care. So a number of countries in the region are trying to shift the focus from just what happens in the facility to what happens to the whole population at risk, to the broader community. And in this model of care, model of primary care, there is then an opportunity to address climate hazards and environmental determinants of health. And so that was actually the second topic that they thought was important. Then they thought about pollution and health. And of course, they're thinking, I would imagine, of air pollution, plastic pollution, water pollution, and so on. So quite a variety of different things. Emergency and disaster preparedness for climate hazards. And what does that mean and how does one do it? A lot of facilities have thought about preparedness in relationship to other hazards like pandemics or sometimes things like fire in the facility and so on. But very few have actually thought through preparedness for climate hazards that might be prevalent in the area. How to make your facility and services more climate resilient, and what are the issues there that one might pay attention to? The health and social effects of extreme heat and heat waves, mental health and psychosocial counseling in disasters. We often in disasters think of all of the sort of more physical issues around gastroenteritis and maybe injuries, But they were emphasizing that actually we need to think a bit about mental health and psychosocial counseling as a topic. And then lastly, which sort of goes hand in hand really with the climate hazards, is how to make your facility and services more environmentally sustainable. So these were the top sort of more specific CPD topics that they thought were relevant to the workforce. They then said, actually, yeah, that we get a lot of CPD on these clinical topics, other clinical topics that are listed here, but we never get any information about the relationship of these topics to climate change or to broader sort of planetary health issues. And so they were saying or agreeing with the fact that planetary health sort of information, relevant information, should be embedded into broader CPD on these particular topics. And you can see it really does cover the whole burden of disease, from respiratory disease to diarrhea, malnutrition, infectious diseases, mental health, injuries and trauma, maternal and neonatal health, and non-communicable diseases, particularly cardiovascular and diabetes. So they're really saying almost across the whole CPD menu that we should be having, in that 30, 45 minutes, we should be having 5 minutes on how does climate change or planetary health issues impact on this clinical topic. So the implications of this for us, and this is what we're busy with this year, is to maybe in the first set of more specific CPD topics to develop some CPD articles that target this and which would be published in a special collection in the African Journal of Primary Healthcare and Family Medicine, and then linked to ECPD so people can also get accredited for this, and linked maybe to other educational resources or potential speakers in the region who could address these issues virtually. And then for the clinical CPD topics, to provide, your traditional clinical speakers with some resources that they could embed into their talks. So maybe some pre-prepared PowerPoint slides with good links to the evidence, maybe some video or even podcast material that could be embedded into your traditional CPD. So that's kind of how we're seeing the way forward in Africa for incorporating this into in-service training of the primary care providers. In terms of postgraduate education, just to give one example from family medicine. So within the Master of Medicine degree, which is the training of specialist family physicians in the African region, we have embedded this topic into the modules that look at leadership. So people who are offering leadership to the clinical team within a primary hospital or a primary care facility should then be thinking, as the WHO suggests, about climate resilience and environmental sustainability. If you look at the measurement framework for primary healthcare put out by the WHO after the Astana Declaration, that service delivery has three components: the model of care, systems for quality improvement, and then the resilience of health facilities and services. And so leadership needs to also address the issues around resilience and environmental sustainability. Then, as I mentioned earlier, as we lead the implementation of community-orientated primary care and the strengthening of primary care to include a focus on the environmental issues, the climate hazards, and then finally in the training around ethics and human rights to incorporate this topic as one of the key features in that training. Undergraduate education. So it's really important, of course, that, okay, so we've got the existing workforce, so we need to do in-service education to bring our workforce up to speed. And then the next generation of healthcare workers, they need to be better prepared. So we maybe have to do less in-service training. And so undergraduate education or pre-service education is really important. One of the things I think that we all recognize is that curricula are very full. And so, you're not going to have success with, trying to insert, a new module on planetary health or One Health or whatever. You're going to have to thread this through the curriculum. And in fact, at Stellenbosch, we've been very lucky to have a new curriculum. This is actually for medical students, this one, that has been introduced a few years back and gave us the opportunity to think from the start, actually, about planetary health. So just to show you how we embedded and threaded this through the curriculum. So this actually is the first 3 years of this new curriculum for medical students. So in years 1, they have 2 modules. The first one looks at being and becoming a health professional. The second at the form and function of living systems. Then in year 2, they look at health and wellness. And then moving to dysfunction and pathology and so on. Then medical detective, all of the assessment issues, and then interventions, all of the therapeutic and other interventions. So that's sort of in very broad terms the first 3 years. And in each of these modules, we're now thinking about these issues from the self, the student, the emerging health professional, from the point of view of the patient or the user, the health system, the community, and then what we've added, in a sense, is at the top of the system, the planet. So if you look at how we've threaded this through, we've essentially asked key questions in each module that we try to answer. So in the first module, we look at, why is planetary health relevant to future health professionals? In the second one, we look at how does the sort of form and function of the planet, the ecosystems, support human health? In the third one, we look at what are the co-benefits of a healthy and environmentally sustainable lifestyle. So issues of, for example, I think you've probably seen that the Lancet recently published the planetary health diet, and looking at how that diet is also potentially a healthy diet and the co-benefits of the two. Then, sort of more traditionally, how the ecological crisis impacts health across the burden of disease, and also the health system, the health facilities and services, which is another important topic. Then in the next module, taking that forward. So how do you then actually evaluate the climate resilience and environmental sustainability of your facility or service? Our medical students spend the first 3 years of the curriculum in primary care facilities, the same primary care facility for 3 years. So they address this issue in their primary care facility. And then in the last module, they take their assessment and they look at, well, how then do we strengthen the climate resilience or environmental sustainability of this facility and its services? So some of the key activities that they engage with on campus, I think as was mentioned in the introduction, the Faculty of Medicine and Health Sciences at Stellenbosch have formally joined the Global Green and Healthy Hospitals Network as an educational institution. So that brings into our consciousness the 10 agenda points that they have for environmental sustainability. So the idea is, of course, to make the campus environmentally sustainable and to therefore also help our students to behave as environmental stewards during the 6 years or the 4 years or the 3 years that they spend on campus. So they practically emerge as health professionals who already behave and think differently. Of course, they also get standard lectures. We have some panel discussions, and they also have a campus wellness day where they put together the health and wellness issues. On the primary care platform in these primary care facilities, sometimes we get them to evaluate the climate resilience using a vulnerability and capacity assessment tool developed by the Climate Action Accelerator. Sometimes we get them to evaluate the carbon footprint of the primary care facility using a tool that Healthcare Without Harm have put forward and which is relatively easy for students to use. This year, actually, they're evaluating waste management practices in the primary care facility. And then what they discover, they take forward as part of learning how to do a quality improvement plan. So as they learn about quality improvement, they look at the issues around climate resilience and environmental sustainability. So that's how they practically put it into action. So those are my thoughts. I think I was given 15 minutes, probably spoke for some, more or less that. Yeah, happy to take any questions. I see it seems like I'm asking a question. I'm not quite sure how that hand came up. Okay.
Thank you so much. Thank you so much, Professor Mesh. It was a very good overview on the types of capacity building and education that we can provide since the continuing education and also including this knowledge in undergraduation degrees. And I will continue these insights with our next presenters that we'll have Dr. Maria and Dr. Ursing. Dr. Maria is a distinguished public health professional with extensive experience in public health, environmental health, and climate change and health. Her work spans collaborations with governments, international organizations, and tertiary training institutions in across number of countries in Africa. She currently serves as an assistant professor at the University of Global Health Equity, where she is a course director of climate change and health at the Center of One Health. Beyond capacity building, she is committed to mentoring and nurturing the next generation of health professionals in resource-limited settings. Her contributions continue to inspire emerging health leaders worldwide. And Dr. Ursing is a medical doctor and global health leader with expertise in neglected tropical diseases, One Health, and socially grounded global health research. He holds a MD from the University of Rwanda and a Master in Global Health Delivery from UGHE and a PhD in Global Health with a focus on social science from Brighton and Sussex Medical School in UK. His work bridges research, academia, and national level public health implementation with a strong emphasis on integrating One Health into medical education, advancing One Health approaches into NTD control and prevention, and strengthening pandemic preparedness and responses. Dr. Maria and Dr. Ursing, the floor is yours. Thank you so much for being here with us today.
Thank you so much. And I will just proceed from where Prof has ended in the presentation. And we are going to be focusing on why we actually train our medical school students on climate and climate change and health. So basically, to just give a highlight of what our training is on in terms of medical school, because these are two different areas that naturally don't get together. So we do this to prepare them to improve their working conditions. And as you know that health facilities are the most needed facilities during the extreme weather events, because most of the affected populations, they will want to access services at that particular time. So we train them so that they can understand and be able to strengthen the infrastructure within their facilities in relation to with other sectors or with other stakeholders like engineers and so on. So with climate change, even facilities that have never encountered impacts of climate change like floods, now it gives a challenging moment for people who work in these settings to take actions that are more than what they usually do in their normal profession. So we train our medical school students, including the staff from the medical school, so that it is easy for us to move forward. And when they go to the clinicals, it's also easy for them to understand what to do when the extreme weather events come. So for those who, for example, find themselves working in facilities that are in the flood-prone zones, they should be able to actually advocate things like elevation of foundations, to advocate for improved drainage system so that flooding affecting the services of the facility and many other kind of actions that are required from the professionals working from these facilities. We also train them to that something like reinforcing the facilities just right for these facilities to remain functioning during the disaster. We also encourage them and understand that so long as they are working in these facilities, they need to remain safe so that they can still offer the services that the community requires from these settings. So this kind of safe environment also extend to the patients. No one wants to see patients come to the hospitals and then they get even more injured because the hospitals are not prepared or the health facilities are not prepared. Also, this will also involve the extension or the integration of occupational health services or safety measures that will safeguard the professionals themselves and the patients as well when the needs arise. Next slide, please. Yes, so basically, like I said, you find that things that are related to climate change are kind of completely out of the medical curriculum. So we want them to understand how the greenhouse gas emissions are related to climate change and how health facilities are actually contributing to that. I think the prof talked about carbon footprints within the health facilities. We want them to understand how actually health facilities contribute to greenhouse gas emissions and how they can contribute in reducing that emission by adopting practices that are sustainable. Practices such as, for example, we know hospitals actually contribute to or health sector generally contribute to about 5% of global greenhouse gas emissions. So once they understand that, it is very pertinent for our professionals to know what they can do to cut this emission. For example, the use of incineration, the use of electrification for lighting, for heating, for all the services that they do in the hospitals, they can actually adopt better and sustainable clinical practices such as, non-burning clinical waste management approaches, such as encapsulation, such as we teach them to think of, solarization. I actually saw some professionals from health facilities asking of how actually they can cut some of their electric utilization by adopting solar systems for some of the functions or some of the services that they give. And I think something about waste management within the hospital setup. Those are mostly hazardous waste, but with the segregation approaches, we reduce the amount of waste that goes into incineration or that will need a lot of maybe electricity or burning, and therefore reduce the emission. And that could be more environmentally friendly practices. Next, please. Yes. So apart from mitigation, we also want these health facilities, including the health professionals themselves, plus the patients, to be able to cope with the impacts of climate change. So that will be an adaptation. So their main job is to treat, but in this context, we want to incorporate into what they normally do, which is to identify and manage climate-sensitive health conditions. I know that within health setting, we know that they normally capture data, they treat patients. So we teach our students not just to treat the symptoms, we teach them to ask even further questions that are related to environment, that are related to climate, that are related to One Health generally. So because this module is within the One Health course or One Health department, we go beyond the climate, and the climate is just a component of One Health. So we will see when we are looking at the actual clinical part, the primary care, what do they normally do in terms of the guidelines and so on. But we train them to recognize and identify the the climate sensitive health impacts in the communities, things like vector-borne diseases, malaria, dengue, the habitats, and so on. Sometimes we take them into the field, they get to learn what happens to the population of the vector, like mosquitoes, what happened to the vegetation, and how vegetation actually for low flooded areas contribute to the health issues within the communities. We also train them how to prepare for emergencies, not just responding, we also look through the preparedness. So things like emergency preparedness plans, the communication channels, and then the drills of if these plans are actually working. And these are basically things that we train them that are normally not necessarily part of their normal medical curriculum. So with that, we also teach them how to educate the community and community health workers, all those community level frontline workers who actually work with them of the emerging or the existing climate sensitive the impacts in the community that they serve. We are very located in the rural area of Rwanda, and there are some common things that students can actually pick. They go through the field schools, through One Health Club, they go to the community, they get to learn a lot of these things. And finally, we also teach them how to advocate for updating of the clinical guidelines that they will be using when they go into the practice. And from there, I think you will actually appreciate from Dr. Arsen's presentation how we are actually doing outside the classroom at the hospital setup or at the facility itself. Thank you so much, and I'll let Dr. Arsen to proceed.
Thank you, Dr. Maria, for explaining how we expose our students, both the ones doing MBBS, who are being trained to become doctors, and the ones who are in master's degree to the practical realities that exist in our communities leading to climate change and how that is applicable to in health facilities. So maybe to add on what Dr. Maria mentioned, we adopted a term One Health to describe or to demonstrate how our educations include the human, animal, and environmental aspect across the entirety of its curriculum. And by that, for example, going to medical training, we acknowledge the exposure pathways that include extreme weather event, heat stress, air quality, food supply and safety, vector distribution and ecology, and we link it to health conditions that the medical students are being trained to deal with inside health facility, and how we designed the curriculum to prepare these doctors to understand those extreme weather events, the heat stress, generally to understand how climate change can affect health directly, is what I'm going to discuss into the following slides. So we start with One Health history. The One Health history, as I said, includes three components. And the first component, which is the one we are talking about, particularly in this session, is the environment. And we want our students to understand what type, for example, how is their patient come from, what kind of heating they use, what is their water supply, how they dispose of the sewage, or is any hazards in their neighborhood. We are including air pollutions, flooding, any extreme weather event. So this is incorporated in the One Health history, which is basically a traditional history taking done in medical school plus the One Health component. And then there is an animal contact. We want to make sure that our students can relate to or can understand quickly the connection between interaction of humans and animals, and our students are trained to identify zoonotic disease easily and link it to what might have happened in the community where the patient is coming from. Lastly, we go to occupations. We want to know what kind of work they do, whether they use personal protective equipment, and all of these help the students to link or to assess the patient from a holistic, comprehensive point of view, so that they can get to connect all that can happen at the interface of human, animal, and environmental health aspect of the patient. So, for example, here we are showing a table of how we train our students to understand the pathophysiology of the conditions. There is what is taught in traditional medical school or in the traditional medical curriculum, which include mostly the disease, the pathogen, and then maybe the vector, and then it jumps to the syndrome. At UGHE, we also have a focus on this particular environmental aspect of these conditions, so that the students know the vector range, the factor affecting the range, the disease distribution, and the animal host. And with this model, students understand all aspects of a pathogen. They understand their life cycle. They understand what climate aspect influence the vectors, how those vectors move from one country to another, or how people move from one country to another, and how it affect the disease distributions, and then finally understand how the vector operates in the animal hosts. I'm not trying to go into all these details, but if we take, for example, an example of malaria, which it's a very common conditions, and using the example of Rwanda, it is throughout Rwanda and it's highest in eastern and southern province. And the factor affecting the vector range is increased temperature that continue to support the widespread of the mosquitoes. And the animal host is not applicable, which is for the case of filariasis. Sorry, it's not malaria. So these conditions show the teaching of students using, including and talking extensively about the climate effect and the disease distribution, allowed them to ask the kind of questions that I presented in the previous slides, and help the students to get a clear picture of all environmental aspects contributing to the disease they're trying to diagnose and understand in their patients. There are barriers that we acknowledge at UGHE to training climate resilient, or to including climate resilient materials in medical school. The existing academic regulations do not provide scope for interdisciplinary education. So there is also advocacy at the level of UGHE, at the level of Rwanda in the region, through international conferences or consortiums, to adopt or to amend policies that prohibit or that resist the integration of these materials in traditional medical school curriculum. There is already congested medical curricula. There is a sufficient number of medical educators trained in One Health. One Health, from our perspective, include also planetary health. And measuring impact is still an issue, since these initiatives are relatively new, and the evidences of the change it make are still being collected now, and it might require also extra resources. So UGHE have developed, for example, clinical guides, One Health clinical guides, to help our students to also incorporate those strategies of understanding a patient from a comprehensive perspective, even in clinical practice. So in basic medical science, the One Health aspect of disease, of medicine, of different system, cardiovascular, respiratory, neurological, are incorporated in a module they take in basic medical science, which is year 1 and year 2. And then from year 3, in which they start clinical rotations, they have a reference guide for the wards and clinic that helps them to understand the conditions and link them to climate aspect, to animal aspect, to all aspects, including in the One Health triad. Thank you. This is at the end of our presentation.
Thank you, Maria. Thank you, Ursing. This was amazing to see how your university is advancing in this topic and how important it is. I think in the two last presentation we saw how capacity building education is important, not only to produce knowledge, but also to help health professionals to identify their role and also their responsibility to act in climate change and health due to the whole impact of climate change is doing in our health. So they have this responsibility, they have this role to build a resilient health system and to take care of their patients. I would like to invite our next presenter. It's Dr. Brian Sibanda. He is a social scientist experienced in fostering collaborative environments that enhance interdisciplinary research at the intersection of gender, climate change, environment, and health, with a proven ability to develop and implement innovative methodologies tailored to diverse community development settings, committed to translating academic research into actionable strategies and intervention that support sustainable development and resilient health systems. Is skilled in mentorship and capacity building to empower emerging professionals in social science research. Professor Brian, thank you so much for being with us, and the floor is yours. You can share your screen. You can start. Can you see that?
Yes, please. Good day, everyone. As already been said, my name is Brian Sibanda. I am part of an awesome team led by Professor Stanley Lucas, who is the Executive Director here at SESHA Zimbabwe, as well as Dr. Fortunate Machingura, who is the Director for the Climate, Environment and Health Department. We are conducting a study in Mount Darwin, which is called the Healthcare Worker Study. The Healthcare Worker Study seeks to understand the impacts of heat on healthcare workers, how heat affects healthcare workers, as well as the quality of care that they give to their clients, as well as how heat affects the well-being of healthcare workers, their mental and physical well-being. Why is this important for policy? The United Nations, as well as the World Health Organization, have identified climate change as the single biggest health threat facing humanity. And healthcare workers face most of the brunt of such phenomena, especially in resource-constrained settings in our African context, such as those conditions pertaining in our study area, which is Mount Darwin district in Zimbabwe. So a resilient health system, therefore, depends on how productive and empowered healthcare workers are. So part of our study is shown that the facilities in most of the areas where we work lack thermal comfort in terms of offering working environments that are comfortable to healthcare workers. Next slide, please. evidence from our formative study have shown that facilities in our catchment area, which is Mount Darwin in Zimbabwe, where we worked in 3 facilities, 1 hospital and 2 clinics. These areas face a lot of high indoor temperatures, and these conditions have limited thermal protection for healthcare workers. So healthcare workers suffer the double tragedy, one of trying to offer the utmost quality of care to their patients, while at the same time they also try to cope up with the heat that is existing in their environments. Healthcare workers therefore report issues such as fatigue and dehydration and stress, as well as reduced concentration. And most of these adaptation strategies that exist in these facilities are on an individual basis and not on facility or system-based system. Next slide, please. Next slide, please. From our formative study, through our qualitative interviews, our healthcare workers indicated that they face discomfort due to the heat that pertains within the working environments. This forces them, therefore, to rush or expedite the processes, and in the process, will miss important points or overlook patient complaints. This was from part of our IDIs. And then from our survey, most of the healthcare workers indicated that they face heightened irritability as well as poorer communication with their patients as a result of the ambient heat that is there within their working conditions. Next slide, please. We therefore encouraged healthcare workers to come forward through the co-creation processes, whereby based on our formative study, they came up with interventions that are responsive to their particular context. This was also done in conjunction with various government institutions and various partners, such as some other non-governmental organizations, line ministries within our working area, as well as the local leadership. In our case, our local chiefs and our local headmen, they're also there in the co-design process, whereby healthcare workers led us through a process where responsive interventions were proposed that could offer some sort of thermal comfort and adaptation to their working environments. These interventions were clustered into behavioral interventions, health system, and built environment interventions, nature-based solutions, as well as policy action interventions. Next slide, please. So through the co-design processes, our healthcare workers managed to identify or recommend various interventions that could help them have thermal comfort while they are working. For example, for the behavioral aspect or the behavioral pillar, healthcare workers are suggested to have hydration stations within their health facilities so that they could have water whenever they felt thirsty. From the built environment pillar, healthcare workers recommended ceiling installation, water storage tanks, as well as shading structures and air conditioners within their working environments or their wards. On the nature-based side, healthcare workers suggested that they have trees planted around their facilities so that they could offer shade. And they also gave recommendations on policy and governance to say there should be a technical working group that was responsive to their climate change or their thermal comfort needs. Next slide, please. So through these iterations, our healthcare workers managed to lead the co-creation processes. And through their input, we managed to come together and come up with interventions such as these that you are seeing there on your screen. On your top left, there is one of the facility managers leading the collection of water or leading hydration efforts through the water dispenser. In the middle there, we have messaging screens whereby healthcare workers are getting reminders on when to hydrate, to sit in the shade, and also finding means of trying to avoid direct sunlight. To your far right, there is an illustration of our healthcare workers during their ANC HEAT talks, where they capacitate pregnant and postpartum women who present to the facilities in the morning. They give education on the importance of staying hydrated. They do this after they themselves have been capacitated on the effects of heat on their bodies, on their mental health. And also they impart this to the pregnant and postpartum women to say how much heat can affect the unborn child as well as the newly born baby. Below, there are some of the interventions that we've had in the facilities, such as the air conditioners and the fridges, as well as cooling kits. Next slide, please. We have had 2 demonstration labs in the areas that we work in. On your top far left, this is the old facility, which is called Lotito in Marsh Central. After the interventions, it transformed to the picture there on your right, whereby the roof has been painted white to reflect heat. And within these facilities, a lot of improvements have been made inside, such as having new ceilings and ventilation. Below there is our Mount Darwin District Hospital. On your left there is how the hospital was before the interventions. On your right there is how the hospital presents after the interventions. The roof has been painted white to ensure the cool roof, as well as some interventions have been put inside, have been made inside the facility to make it comfortable for as a working environment. Next slide, please. All right, and then we have empowering cycle of healthcare workers, where we have identified that it is important to make sure that healthcare workers recognize the risk that is portrayed, that is presented by ambient heat. Having recognized this risk, healthcare workers are therefore able to design solutions and are not only beneficiaries to the solutions, but are co-creators as they are aware of their immediate needs in terms of heat. This also leads to healthcare workers leading the adaptation and mitigation strategies and interventions that are there in our facilities, which we have observed. This has also seen the healthcare workers strengthening a sense of ownership and responsibility, which ultimately ensures that these interventions are going to continue well after the organization has left the particular area. Next slide, please. So we've noted the heat transformation cycle that we have as a result of these interventions, or as a result of our interactions with healthcare workers. We have noted or have identified heat as the background challenge. Prior to our operation in this area, healthcare workers indicated that this is a hot area and they had acclimatized to the area, but now they are aware that heat causes a lot of major health risks, and this has improved their awareness and has led them to coming up with the localized solutions within their context, and has made them actively manage their thermal needs, such as the hydration, and they offer peer support in terms of leadership and in terms of helping each other, reminding each other in terms of hydration partners, which we call the better parties. Slide, please. So this has resulted in the heat resilience pathway, which you've noted, whereby after being capacitated and having this knowledge imparted to them, the knowledge increases in healthcare workers due to peer learning. Their literacy in terms of their knowledge of heat and its effects on their bodies and on their working conditions has heightened. This has also increased their adaptation strategies and readiness. They're able to iterate and come up with innovative cooling strategies. And this has been embodied in their workflow. They've internalized this into their workflow. And if this has reduced the strain and the mental strain that they face when they are executing their duties, probably leading to sustained performance in terms of the quality of care and improved quality of care that they give to their patients. Next slide, please. So we've discovered that there are certain roles that each and every one of us plays to come up with these resilient health systems. For example, the healthcare workers, having been capacitated on climate change and the effects of extreme temperatures, they are able to identify the risk that heat poses and also come up with adaptive practices to take care of themselves. While it's for researchers, it is important that we generate this evidence and then probably upscale these to policy and escalate these to the policymakers who are therefore responsible for creating the enabling policies and standards within our communities, which are resource constrained. Messages, therefore, is that there are the dangers caused by climate change are real, and they affect humans in their capacities, and there's need for having heat and climate resilient health facilities within our communities. This also calls on for national governments to come up with responsive policies as well as partnerships between ourselves as researchers as well as national governments to infuse climate change policies within our trainings, be it for healthcare workers or be it any level of education, so that this is embedded and becomes routine in our day-to-day lives. I think this brings to the end my presentation. I would have loved to show our partners and funders from the slide that I sent, but I'm sure it's not coming up there on the screen. Thank you so much for this opportunity. Over to you.
Thank you, Brian. Thank you. And I'm sorry, I was disconnected in the middle of your presentation. I can share here your partners and everybody, sorry. So thank you so much for this amazing presentation. I think I want to highlight 2 points, and that was also mentioned in Maria's presentation. One is the importance to health professionals also self-protect themselves and be able to be in a good physical and mental health to assist and to care of their patients. And also you brought us a very good experience on how we need to build together with the community these solutions that are also align with their realities, with their culture, and with their resources. So these solutions being successful and make sense to this population. I will call our next speaker because I want to have a discussion at the end. Our next speaker, it will be a little bit different, but I will give you a little bit of context. Because when we're speaking about resilient health system and also sustainable health facilities, we thinking about a lot of structural changes and renovation and technologies, and most of the time some facilities receive some grants to renew and to build this resilience to climate change. But the most difficult thing is to maintain this structure, because people in that place doesn't have the skills and the capacity to maintain the equipment. So I'm going to call our next presenter, who is going to talk about this, how it's important also to build the capacity of some workers to maintain this resilient health facilities. So our next speaker is Britta Johnston. She is a medical engineer and program manager at the Build Health International with extensive experience designing, installing, and maintaining medical gas systems in low resources healthcare settings. She leads technical and operational training for hospitals, engineers, health facilities, leadership, and ministries of health, and coordinates multi-stakeholder infrastructure projects to deliver sustainable, locally driven health system solution. And Brita holds a bachelor and a master degree in biomedical engineering from the Northeastern University with a focus on biomedical instrumentation and medical device design. Brita, over to you. Thank you so much.
Thank you so much. Let me share my screen and then we can get started. Great. Can you see my screen okay? Great. Well, thank you everyone for being here. I am, as you just heard, a biomedical engineer with Build Health International, and I'll be presenting on building biomedical engineering capacity in healthcare systems. So I'll give a little bit more background on Build Health International for those of you who aren't familiar. Build Health International is a nonprofit organization, and our goal is to improve access to and build capacity for dignified, affordable, and high-quality healthcare infrastructure in resource-constrained settings around the world. And capacity building has always been a central part of the work that we do. From our first project, construction project building a hospital in Haiti, training and equipping workforces has been critical, we believe, to not just the project success, but the long-term infrastructure success. The on-site and local staff are trained, in trades like carpentry, plumbing, electrical work, and their ability to maintain the facilities after the construction project is done is what makes our projects a success. And we now have a large cohort of highly trained staff at the facilities that we work with. More recently, we've expanded our training throughout the African continent. There's a construction project in Sierra Leone for a maternal hospital that we're working on, as well as trainings with clinical staff and biomedical staff, or not clinical, but clinical engineers and biomedical engineering staff at facilities. In 2017, the World Health Organization explicitly said that clinical engineers use their specialized engineering knowledge in implementing healthcare technologies, and that these healthcare technologies are used and are critical to the delivery of safe and effective healthcare. So they're basically saying, you know what, us clinical engineers have known for a while, which is that as technology and equipment becomes a more central part of healthcare delivery, so do the people that keep that those pieces of equipment up and running. And so we consider technical staff at hospitals to be essential healthcare workers. So Build Health International has obviously, done a lot of training and capacity building of staff on site for a long time, including medical oxygen systems. With the advent of the COVID-19 pandemic, we really saw two things. One, how critical oxygen is in healthcare delivery, and two, the gap that exists in a lot of healthcare systems. So we, really focused a lot of our resources on training in implementing, preventative maintenance plans to keep oxygen plants up and running, installing new plants, and designing medical gas systems, all with the goal of sustainable provision of medical oxygen to patients. And we've been able to have a lot of success. We've trained over 2,000 technicians and healthcare personnel since 2022. I've been able to be a part of 12 of the trainings, and they've, varied widely from Kyrgyzstan to Nepal, to Uganda and Rwanda and Sierra Leone. So we've been able to reach quite a wide audience. Some of the challenges that we see with capacity building. Medical equipment generally is tested in very controlled environments, and it's designed and built in controlled environments. And so when they're brought into extreme environmental conditions where they're often installed and operated, they're more likely to wear and break down. And, these environmental extremes are becoming more frequent and more extreme with climate change. And we've seen that, as an example in Niger, hospital we've been working with, their oxygen plant has faced more frequent breakdowns because of the extreme heat that the plant has to operate in. So it's even more important that the on-site staff is able to address these breakdowns and conduct preventative maintenance to prevent the breakdowns. On-site biomedical staff we've seen also struggle with procuring spare parts and receiving technical support for troubleshooting equipment. And so that's a critical part of this too, is the supply chain that they face, supply chain issues. So, our our rallying cry here is that to support rural and hard to get to facilities, it's necessary to improve self-sufficiency as climate-related events occur. And the other side of this is that the remote training opportunities and remote support that we can provide reduces greenhouse gases and travel for not just BHI team members, but also for manufacturers and suppliers who often will fly in internationally to conduct maintenance or repairs. So we believe that preparedness is key and capacity building of on-site technical staff is important. So I'm going to dive a little bit deeper into some of our training models and what our trainings look like. So how do we get from our training, week-long training to having oxygen plants operating sustainably and keeping a sustainable supply of oxygen to the patients? So our hope is that the trainings that we provide, 2-day or 5-day trainings, along with continued remote support for the trainees, results in application of the knowledge that they learn over the course of the training. So this can look like, routinely filling out preventative maintenance logs from the technical staff, or maybe it's allocating budget year after year to the maintenance of the PSA plant from the administrative side. And the result, we hope, is that the plants break down less because preventative maintenance is being done, or that when they do break down, that the repairs happen quickly because they have access to spare parts that have been budgeted for by administration, and the technical staff has the training and the skills to be able to conduct those repairs quickly. So we deliver a general maintenance training, and this is to cover equipment, operational theory, daily preventative maintenance, and simple troubleshooting. We also have an advanced training that's also 5 days for more senior engineers and technicians, and that includes advanced troubleshooting, complex equipment maintenance, and common repairs with a lot of hands-on practicing of the repairs and maintenance procedures. And then we also have a management training. So we've found that, management and administration in healthcare facilities is a critical part of keeping equipment up and running. Because if the technical staff on site, they might have the training to do the repairs, to be logging the information they need to know when to do the repairs, to know what parts they need to do the repairs. But if the administration isn't willing to allocate funding to buy the spare parts and plan for having the spare parts on site, then the repairs can't happen. So they're a critical piece of this ecosystem. And so we've really focused on creating a training for management on, general operating requirements of the equipment, but with a large focus on human resource planning and budgeting for operating costs for the equipment. So there's a lot of preparation and logistics planning that goes into these trainings. Before the training, we really want to consider the trainee technical background, especially with the general maintenance training. We see a range from trainees who have advanced technical degrees to trainees who may be struggling with literacy. So obviously the delivery of these materials will vary widely depending on who we have in the room that we're delivering the training to. And we also focus on what type of equipment are at hospitals. Different equipment has different maintenance requirements, so we want to, target our training to be as effective as possible. During training, activities vary widely from classroom lectures to equipment practicals, where we're all in the plant room working with our hands on the equipment, to workshops ranging from spare parts planning to, electrical cost budgeting as some examples. And the after training follow-up is what we see as really critical part of this training to make sure that the everything that's learned in the classroom can then be applied once all the trainees return to their facilities. So part of this follow-up is provision of toolkits. So each facility represented at the training will receive a toolkit from BHI with what we believe to be the most critical tools for keeping the plant operating and conducting maintenance activities. We also provided maintenance logbooks so that the technical trainees can fill out and record all of the maintenance work they're doing, as well as creating WhatsApp group chats, which I'll talk a little bit more on in a little bit. But we create a WhatsApp group chat so that the trainees can request remote support from our technical team at BHI, but as well as from each other, from their cohort and their colleagues that they're working with. So we can talk through some resources and opportunities. Educational resource for biomedical personnel that we've actually just launched is we've launched a video remote learning version of the training materials that we typically deliver in person. So anyone can go onto our website and watch this material, which can range from slides to walking through some of the workshop activities to videos walking you through step by step how to do certain maintenance activities. So we're really excited about this so that this training material is not dependent on us being in person. Now, hopefully it can be accessible to whoever's able to watch these videos online. We also have a technical support website, which is linked here. So for anyone who would like to request support with their oxygen plants, then we can direct them to resources that would be most helpful to them. So whether that's a request for training, a request for support troubleshooting, we wanted to have this resource available, and it can also result in just adding people to our existing communities of practice. We also have a training center, a brick and mortar training center. For those of you who are based in Rwanda, it's at IPRC in Kigali, with a full oxygen plant with multiple different types of equipment, where we can really get into conducting hands-on maintenance tasks with trainees. Oftentimes when we deliver trainings, there's some challenges with, really fully taking apart equipment because they're at a hospital and the hospital needs to use the oxygen. So having this training center has been really helpful in being able to demonstrate some more intensive maintenance tasks. And we've had trainees both from within Rwanda and as well as international cohorts traveling to this training center from Ethiopia and soon Uganda to receive more advanced technical training. So future opportunities for biomedical capacity building, we would love to see more remote support options for a lot of our trainees and a lot of the biomedical engineering staff at facilities. Our WhatsApp communities of practice, we have two examples shown on the slides here of times when either our technical team or other trainees in the chat have been able to help other trainees troubleshoot equipment, repair equipment on their own without any in-person intervention. And we see that as a huge success and an opportunity to continue that. The other opportunity for capacity building we see is access to equipment manuals. Oftentimes, equipment is purchased or donated to facilities, and the manuals for that equipment isn't sent. And without manuals, it's really difficult to be able to maintain and repair equipment. So, making sure that equipment is provided, or that the equipment manuals are provided with equipment, and pushing for suppliers and manufacturers to make those manuals and that documentation more accessible online would be a great opportunity to support biomedical engineers. And then lastly, touched on this when we were talking through the management training side of things, but administrative prioritization of biomedical personnel needs, involving biomedical personnel, in decision making on administrative level and making sure that they have the resources they need to maintain equipment and to continue learning more and getting more technical resources will be a great way to further support their capacity building. So thank you, everyone. And then I guess I'm not sure if there's time for questions now, but if you have any additional questions, you can contact us here as well.
Thank you so much. That was very interesting, and as I said before, this is a very important topic when we're considering sustainable health systems, to make sure that people are able to maintain the structure that was built to be more sustainable. So I would like to invite all the speakers now to open your camera so we can have a final discussion with the questions that we have from the audience. Dr. Maria, Ursine, are you there? Please turn on your cameras. And Brian. Great, we are all here now. So thank you so much for this presentation. I think we have an overview all among the different levels of capacity building, from the undergraduation to master and doctor programs, and also continuing education, community, a little bit of government, and also the capacity building of the technical workers. So it was an amazing overview, all the necessary works that needs to be done in this context of capacity building and climate change and health. And I have some questions. I will start with, I think, with Professor Mesh, and also Maria and Ursine can also share their experience. People are asking about how was the planning to integrate climate change or One Health into medical degree education. I think most of the what they want to know was how to decide to create a new course, how to decide to embed climate change into a course that it's already existing, and what is the best way, and maybe you can share your experience, how you took this type of decision. So.
Okay, thanks. So I think in many African countries now, it's not that hard to sell the need to include planetary health in the curriculum. Like countries like Malawi and others, it's just become a real obvious issue, for health professionals. So I think that's the first thing. You shouldn't really have to argue too hard why it's important. But then, of course, the real issue is how do you do it? Because as we said, most curricula are established and already chock-a-block, absolutely full. So I don't think you should come and say, oh, we want a new course or a new module or a new whatever on planetary health. I think it's actually probably also better to try and integrate the topic into the existing curriculum. If you have the opportunity, of course, to design a new curriculum, that's fantastic, like we did at Stellenbosch, to really incorporate it into the whole design and planning of the curriculum from the beginning. But otherwise, I think you've got to look at what you've got in your curriculum, and then how can it be threaded through, almost so that, as a sort of graduate attribute. So we actually had environmental sort of stewardship incorporated as an official graduate attribute that then kind of gave us the authority to embed it throughout the curriculum. I think the other thing that really helped with us was I got strategic funding to employ a lecturer in planetary health in the Division of Family Medicine. I think that's probably fairly unique in African medical schools. And I think so that gives you a body to actually do the work, you know. I think the work that we need to do is to engage with all the other clinical departments and the key clinicians that do the training to get them to incorporate elements of this into how they teach, you know, the clinical topics. Yeah, I think the other thing that we're lucky is that in our first 3 years, the modules are not owned by disciplines, they are thematic. So it's multidisciplinary and therefore easier in a way for different disciplines to bring different aspects into the module. Yeah, so those are a few off the cuff thoughts. Maybe others have got some thoughts.
Yeah, let's pass to Orsi.
Yeah, I can maybe adding on to what Prof. Marsh said. I would say that we have a couple advantages or put in place structures that allow us to integrate climate change into medical education at the University of Global Health Equity. One is the university started in 2015 with the mandate to integrate One Health across all its curriculum. That means from the beginning of the university, we were mandated and we have a dedicated team. There is a Center for One Health that does that. So the Center for One Health look at all curriculum at the University of Global Health Equity, be it Master's Global Health Delivery, MBBS, nursing programs, and we make sure that in all relevant modules, One Health aspects, we commonly use One Health term rather than planetary health because we integrate both content related to environmental health, to animal health and human health. And our team at the Center for One Health work with teams in other departments, in medical school, in master's degree, different track. We have up to 4 or 5 tracks in nursing programs to ensure that all relevant modules have that part integrated. That means that there is no additional courses or modules that are created to congest already congested curriculum that exists, for example, in medical school. It means that, let's say, if I use an example, that students, if they're learning about cardiovascular diseases, they get a chance to simultaneously understand the environmental aspect of it. They learn about epidemiology of air pollutions in Rwanda, in Sub-Saharan Africa, in different countries. They learn how it's linked to respiratory condition, to ischemic heart stroke, to COPD, things like that. So the faculty in clinical medicine or in basic medical science, they will teach what they usually teach. And we took time to look at the entire curriculum and identify where we will need to incorporate those additions. They can be related to climate or to zoonotic disease. And we've done that across the entire curriculum, both in the first 2 years of preclinical phase, basic medical science, and in clinical rotations when the students in medical school start doing their clinical rotations, clinical practice. As I mentioned in our presentation, they have One Health clinical guides, and they have they take One Health history, which is regular history taking, but adding the components. And then like that, our students are trained from the very first year of their medical training to think from that perspective in all pathologies they learn, in all medical techniques of understanding a patient, diagnosing a patient, collecting information. Yeah, I'll stop there. Maria, do you want to add something?
No, thanks.
Yeah, complementing this, I think this is very helpful because we have a lot of people here who want to start to incorporate climate change or planetary health or One Health in their institutions, but sometimes they are only one. And I want to listen from you how to also engage other professors, also faculties, to embed these disciplines and this discussion in their courses as well. So maybe you have a little bit of experience on that and you can share with us how was this process, because sometimes it's one or two, and how we convince the whole team to make sure that we will have a very comprehensive curriculum that will cover most of the aspect that needs to be covered in that degree course.
If I may, since, like I said, UGHE started with that philosophy in the first place. And with the beginning of medical school, our medical school started in 2019, and we just graduated the first doctors last week or the last 2 weeks. And we have sessions of bringing on board, let's say, basic medical science on board on when it comes to integrating One Health in medical.
I mean, I,
Great. Yeah, go ahead.
you're frozen.
Thank you.
Yeah,
Of
I
medical
would
science.
add, I think. Okay, go ahead. Sorry, you've unfrozen
Hey.
again.
Yeah, I was saying, sorry, I didn't know I was frozen. I was saying we've had sessions, webinars with faculty, both in basic medical science and clinical division, to introduce them to One Health and show them how they can contribute. They don't necessarily need to become expert in One Health, and we always bring in visiting faculty when needed or relevant expert when needed, but we make sure that the components that need to be reflected are added alongside the delivery of modules provided in medical education. Thank you.
Great, thank you, Professor Mesh.
Yeah, I was just going to say, I think another strategy that we had is we had a Dean's Advisory Committee on environmental sustainability, and we identified somebody from every department that was interested, in the topic. I think you'll find people that are interested in One Health or planetary health. There may not be the head of department, but there might be somebody who can then sort of bring the issue to the fore in that department and their teaching. And then I think the other thing that we're trying, I don't know whether it will work, but as I said earlier, is to create little resource materials that people can easily embed in their teachings. They don't have to be an expert on, how, One Health or whatever impacts their particular condition, but they can sort of then incorporate that easily into their teaching.
Yeah, for sure. That's our very good tips for people who are starting. And I will pass a little bit to Brita, and we have questions connect with that. It says, how do we integrate this other cadres, such as biomedical engineering departments in our training college? And also RAC Training Technical Institute, or this is only for healthcare workers?
Yeah, that's a great question. I mean, I think it's absolutely important to include in the bioengineering curriculum, especially since it's so applicable to the work that they'll be doing in the field once they graduate. And I think the idea of not having a specific, a specific set piece of curriculum that's completely dedicated to it, but interweaving it in the topics that are already covered in the curriculum is a great approach. And whether it's for clinical staff or for engineering, students, I think the same strategy would apply because it does impact, kind of every part of the work that you do.
Yeah, and people are also asking if the materials that BHI provide is also translated in another languages.
Yeah, so we've delivered the training in French, Russian, Portuguese, and I believe Spanish as well. I think our online currently the online resources or the online videos we have just in English, but we're working on getting them translated. French will be the next language. And then a lot of our documents, we have a lot of resource documents, SOP templates, technical resource documents, and those are all translated in about 3 or 4 languages.
And people can find that in some.
They can find that on our website, BHI, our Oxygen website, which is linked in the presentation, and I
Yeah.
can send that in the chat as well.
Maybe you can put in the chat as well, and
Yeah,
I also
absolutely.
can share with them. So I invite all of you to search the BHI website because they are doing such an amazing job in this field. Professor Mesh?
Yeah, sorry, one other thought, going back to the previous topic. There's also this initiative called the Planetary Health Report Card, which you
Yeah.
can Google, I think. But it's a student-led initiative. So the students, and it's not just medicine, it's physio, whatever, nursing, they evaluate initiative. So the students, and it's not just medicine, it's physio, whatever, nursing, they evaluate their own curriculum using the scorecard, and they give the curriculum like a grade, like B- or C or whatever, and it's published globally on the website. So this is quite a good way to motivate your faculty, because if they get a C-, they don't like it, and then they kind of a bit motivated to sort of do something about their curriculum. We got a B, I think, at Stellenbosch, but
That's good.
yeah, that's quite a good strategy. Get the students, who often some of them may see the relevance more than the professors, to use the Planetary Health Report Card to evaluate their curriculum and give feedback.
Okay, amazing. So people can also check the planetary cards to have this information. So thank you so much. We are at the top of the hour, so I really appreciate the discussion. I think it was very helpful. And congratulations to the work that you are doing. I'm part of this capacity building team as well. We also provide education on climate and health. We will have soon online course to the Africa related to climate resilient health systems, and I hope I will advertise and share with all of you and invite these amazing presenters here to be part of the course. Thank you so much and have a nice day. Bye-bye.
Thank
Bye-bye,
you.
everyone.
Thank you all.
Thank you
you.
for the fruitful presentation. Thank you so much, all.
Thank you. Bye-bye.